Thanks. It's great to be here today. When I mentioned to my husband this morning that I was coming, he asked if I was going to start out with a joke, at which point my daughter looked at me in horror and said, "Mommy, you can't do that. You're not funny." I'm going to apologize in advance if my presentation's a little dry. I think as many of you, most of you who've been following federal health care reform probably already know that Governor Patterson has been a big supporter of federal health care reform. He believes that federal reform that expands health insurance and coverage, contains health care costs, and improves the quality of health care would be a significant step forward for the 2.5 million uninsured New Yorkers. He's, in fact, made increasing access to health insurance one of the priorities of his administration. And I think we've made great strides in expanding coverage by making Child Health Plus available to families with incomes up to 400% of the federal poverty level. The governor's made health care accessible to every child in New York. We've also expanded coverage to parents and adults through the Family Health Plus program, which is now available up to 160% of the federal poverty level, and soon should increase up to 200% of the federal poverty level once we have our federal waiver approved, and that will be with federal financial support. Another thing that we've done is to simplify the enrollment process to make it easier for qualified New Yorkers to get and, to, importantly, to keep their coverage. Getting people covered has been a priority for the governor because we all know that lack of health insurance means poorer health, shorter lives, and lost economic output. Medical debt is one of the leading causes of personal bankruptcy. So even with the advances that we've made here in New York, the governor still feels strongly that the status quo is unacceptable. And bear with me for a few minutes while I go through some statistics. As I mentioned before, right now we have 2.5 million uninsured New Yorkers under the age of 65. More than 5 million New Yorkers go without health insurance coverage during some portion of the year. We're lucky that here in New York we have about 11 million of our residents who are covered by employer-sponsored coverage. But family premiums in New York have increased by 97% since 2000 and now average $13,500 a year. And they're rising. By 2016, we expect that family insurance will cost about $24,000 every year. So it's not surprising that more and more employers and businesses are dropping coverage as these premiums increase. And the sad fact is that today, about 1,000 New Yorkers lose their insurance coverage every day. That's why Governor Patterson thinks federal health care reform is so important. But while the bills are being negotiated, he's been a strong advocate for the interests of New York. And he laid out 5 principles to our congressional delegation back in July, and we've been working with our senators and representatives to try to ensure that as many of those principles as possible are addressed in the final bill. And I'll just describe those quickly. So the first principle is that we should leverage Medicaid and health reform. And we thought we were doing a pretty good job of that. I'm a little concerned about your comments earlier, Tim. Second, we think it's very important that all states are treated equitably in the federal health care reform. Third, federal reforms have to be affordable to the states. Fourth, federal reforms need to maintain critical funding streams to our hospitals. And then finally, the governor believes that we need to ensure a level playing field in any insurance exchange program. So the governor is pleased, as I just mentioned, that so far at least the first test to dramatically increase the number of people enrolled in Medicaid has been met. And that's been, we think, a really positive thing. But getting to the financing piece that Courtney mentioned we'll talk about, there are significant differences between the two bills and how affordable this is for New York and other states, and we're working to advocate for inclusion of the best provisions of both bills in whatever the final reform package ends up being. And it does, from everything we've heard, it looks like the Senate bill seems to be the vehicle, and so some of my comments will focus a little bit more on the Senate bill. We're confident that if inequities dealing with the federal Medicaid reimbursement and the current Senate provisions are resolved in the final bills, that New York can afford to continue to meet the mandated Medicaid coverage levels. And although the current Senate bill has improved on earlier committee versions in many respects, still, under the version that's being discussed right now, we project that the increase in our Medicaid enrollment could add close to $1 billion in new state Medicaid costs annually. And given the state's current financial situation, which I think everybody is painfully aware of, which is not expected to improve anytime soon, that's something that we're very deeply concerned about. In contrast, under the House bill, because the federal government finances a larger share of the mandated expansion, we believe that the state will actually save approximately $4 billion in Medicaid costs each year. So that's obviously a huge difference for us. The Senate bill doesn't recognize states like New York, who have been a leader in providing health insurance coverage, because it limits enhanced federal matching dollars, known as FMAP, and I'll talk about FMAP from here on out, only to populations states do not currently cover up to that new federal minimum that Tim mentioned. And remember, that's for adults, it's 133% of the federal poverty level, which is a little less than $33,000 a year. Today, New York covers parents up to 150% of the federal poverty level. And for single adults, we cover them to about 100% of the federal poverty level. We're different than most other states in that regard, because most states don't cover single adults and provide very little, if any, coverage to parents. Under the Senate bill, New York would receive that enhanced FMAP for fewer than 100,000 of the more than 5 million New Yorkers who would be eligible for Medicaid. And that's because, as I just mentioned, we currently provide coverage beyond the federal minimum for everybody but that small population of single adults. Again, just single adults between 100 and 133% federal poverty level. So that's going to be a tremendous impact for us. For everybody else, we're going out that other 5 million population, we're going to continue to pay about half of the cost as a state and localities. In contrast, the majority of states under the Senate bill will receive 100% federal funding for all their single adults and most parents for 3 years, and then they'll receive 85 to 95% federal matching funds after that. Under the Senate bill, in total, the average Medicaid rate for all Medicaid recipients across the country will jump from about 57% to 65%. Again, New York's rate will remain essentially flat at 50%. I'll pick on Louisiana for a second just to give you the comparison. So here in New York, we're going to be getting 50% for all of that 100,000 population. But in Louisiana, right now, they don't cover any single adults at all. And they only cover parents up to 17% of the federal poverty level. That's less than $4,000 of income a year. That's it, that's all they cover. So what you'll see in Louisiana is that they're going to get 95 to 100% federal funding for all their single adults and for virtually all their parents. In fact, there's only 2 states who would receive FMAP's report for a smaller percentage of their Medicaid patients, Medicaid enrollees, than New York would, and that's Massachusetts and Vermont, who you all also know have been leaders in providing coverage to their citizens. So clearly, we're concerned about both affordability to the state and equitable treatment under the way Medicaid is dealt with. But again, switching back over to the House bill, the federal government would pay for 90% of the cost of enrolling New Yorkers under Medicaid. Plus, it would actually increase about from about 50 to 90% the cost for many of those people who are currently enrolled in our Medicaid program. So that's how we see such a huge benefit under the House bill. So while we're pleased that both bills leverage Medicaid to cover our uninsured and help us get a significant number of our million or so currently eligible but unenrolled Medicaid New Yorkers onto the Medicaid, and they do that, as Tim described, through the pay-or-play plans. But we clearly prefer the bill that's going to help us to pay for them, and we think that that's really essential for New York. Again, I can't stress enough, you've all been experiencing, unfortunately, the same thing. The state has been, in terms of the current fiscal situation for New York. We think that the House version or something like that is more affordable to New York, and it's also more equitable. So the governor has been working closely with both of our senators and with our representatives to ensure whatever final product we get looks more like the House bill in this area. And Mayor Bloomberg has joined the governor in this effort because he recognizes that if the state ends up having to spend more on Medicaid, it ultimately affects localities. While if the state, under a House-like scenario, sees a significant benefit, it gives us a greater ability to make changes that localities would like, such as avoiding future cuts and doing more in the area of the local cap on Medicaid funding. So, sticking with the theme of affordability and equitable treatment, I'll shift over to another one of the principles that I outlined, which is maintaining critical funding streams for our hospitals. You might have heard that because we'll have fewer uninsured, our hospitals will be better off, and so the state can reduce our support for them. And we do spend about $3 billion a year right now supporting our critical hospitals. To understand why this isn't necessarily the case, I have to talk about something called Medicaid DSH payments. DSH stands for Disproportionate Share Hospital. So here in New York, DSH payments provide critical support to our public and our safety net hospitals by reimbursing them for substantial levels of care that they're providing uncompensated. Both bills reduce the support, as I just mentioned, because it should follow that as we have fewer uninsured, it should mean that our hospitals have less uncompensated care. But it's important to keep in mind that neither one of these bills will achieve 100% insurance coverage. So what that means is that our hospitals will continue to have some level of uninsured patients who they're treating. This is especially true for states like New York, where we have large immigrant populations, some of whom wouldn't be covered under either of these bills. So while both of the bills reduce support, and again, there's a logic to reducing that support, they do it very differently. The Senate bill cuts $22.4 billion in DSH payments beginning in 2015. The cuts would range from about $800 million to more than $1 billion per year. Under the Senate bill, New York would absorb 1/6 of the total cut because we have traditionally invested in these critical providers. So again, we're very concerned about both equitability and affordability in that provision. The House bill also reduces DSH payments, but it limits the Medicaid DSH cut to $10 billion, and it delays it until after 2017. The other thing that the House bill does that we think is critically important is that it doesn't do that until after completion of a report on the extent to which healthcare reform has actually reduced the number of uninsured, so that we'll have a better proxy for did it really work, have we really reduced our uninsured before we start reducing payments to our critical hospitals who are caring for those people. So clearly in this respect as well, we prefer the House proposal because we think it's more equitable and ultimately more affordable to New York and to our hospitals. Once again, this is an area where we're working with our senators and representatives to try to moderate the cuts in whatever final bill comes in. And this is another area where Mayor Bloomberg has partnered with us because he recognizes that this is a huge issue for New York City's public hospitals operated by the Health and Hospitals Corporation. And I think a lot of the localities who are operating hospitals will similarly find that to be a critical provision. So before you get the idea, though, that we prefer all aspects of the House bill to the Senate bill, it's not true. So I'll talk about some more of the insurance-related proposals where we also need to worry about that equitable treatment and about affordability. Tim talked a lot about the premium assistance, and the governor thinks that is having meaningful premium assistance is really critical to making coverage affordable to people at all income levels. And we think this is particularly true here in New York and in other states with high premium and living costs. And as Tim mentioned too, and did a good job illustrating, without such assistance, sick people will be more likely to buy insurance, making insurance coverage more expensive. So the Senate bill provides more meaningful financial support for the purchase of health insurance for those with incomes between 250% and 400% of federal poverty level. and we prefer that. We also like the full five-year small business tax credit that's included in the Senate bill. Both those provisions we think are preferable to the way the House treats it. There is, however, a provision of the House bill that we prefer. They provide a greater level of assistance for lower income populations, those between 133 and 250% of federal poverty level, and we'd like to see those provisions adopted in the final bill. There's another piece related to this that's included in the House bill that we think is really critical for New York and should be included in the final bill. And that's a study on the need to address geographical indexing of premium assistance to, again, just try to address some of those regional cost disparities. And again, just with overall with the premium assistance, residents in states like New York with high living costs require high levels of premium and cost-sharing assistance to obtain coverage and comply with the mandate to purchase insurance. We think that implementing geographic indexing is going to be essential to make sure that states are treated equitably as laid out in the governor's principles. The last area I'm going to kind of skip over is the Cadillac tax, because I know that John's going to talk about that quite a bit. So instead, the last area I'll talk about are consumer protections in the insurance exchange that Tim described. This is another area where New York has been a leader, and we think it's important to maintain the protections that we put in place here. So we think that whatever reforms end up taking place in Washington should be a floor and not a ceiling in the area of consumer protections. And this is, again, another area where we think that the Senate bill does a better job at meeting the last principle that the governor outlined, which is ensuring a level playing field for New York. Both bills preserve and enhance some of New York's consumer protections by including prohibitions on pre-existing conditions, on lifetime benefits, limits, and on unreasonable annual limits. And we think that those are important, and we're glad that they're included in both bills. But as Tim described how the differences in the insurance exchanges, we think the Senate does a better job at preserving many of the important protections we have here in New York, including guaranteed access and to coverage and prohibitions built on rating of health insurance based on sex and health status. And as Tim mentioned, the reason that we think that is because under the Senate bill, the insurance exchange will be state operated, which will allow states like New York to address our local issues. The approach the House takes, in contrast, is to encourage the national exchange, as Tim described, and they require matching funds from states that would choose to opt out of that and set up state-based exchanges if they wanted to preserve those consumer protections. So we think that in that respect, we prefer to have this exchange be state-operated because it gives us better ability to protect and continue to protect our residents. There is one element of the House bill, though, again, in this regard, that we think is important, and that's that in the House bill, the insurance exchange gives clear authority to accept bids from a limited number of health plans. And the reason that we think that that is important is it will allow us to use the exchange's purchasing power to contain costs and by securing the best prices to consumers. So we prefer that piece of the House bill. Finally, I'll just mention one last provision that's important to the governor, which is access to comprehensive women's health services. This is another case where we strongly prefer the current Senate bill, which maintains the delicate balance in current law preserving access when compared to the Stupak Amendment that I'm sure people are familiar with in the House bill. So, in conclusion, because the governor believes that achieving healthcare reform is critically important for our uninsured New Yorkers, we're working hard with our members of Congress to advocate for the best possible reform bill for New Yorkers. Thanks. I'll turn it over to you.